get started today. I get the kind of boring section today. We're going to start with dry eye. First, we want to thank our sponsors, Tier Care, Sight Sciences, BioTissue, Star with Vision ICL, Sun Pharmaceuticals, J&J Vision, Conroy Insurance Agency. And the reason why I'm going to talk about ocular surface disease, dry eyes, is because it really has a pertinent relationship with surgery, with patient outcomes, and with patient satisfaction. So how do we do this? Let's talk about optimizing corneal surfaces prior to surgery. So as we know, dry eye the definition has really changed over the years. We know that it's really a multifactorial disease of tears and ocular surface due to tear deficiency, but more so excessive evaporation that results in symptoms of discomfort, visual disturbance, and tear film instability with damage to the surface. There's also a neurogenic component to this as well. That's been added with the newest definition of dry eye. And it's accompanied by, the two things we're going to hit home about tonight: increased osmolarity of the tear film and inflammation of the ocular surface. So if we're not treating those two, we're not really helping our patients. We're just masking the problem, but we're not delving into the source of the problem. So a little review. There'll be a lot of review tonight, and this is not to belabor the point. Everyone knows a lot about dry eyes, but it's simply a reminder of why it's important for us as surgeons and primary eye care providers to treat this a little bit differently than we have in the past. Of course, we all know about the 3 layers of the tear film, where we want to really focus on the meibomian glands, which produce lipids, which really keep the tear film from evaporating. Goblet cells of the conjunctiva also produce mucin, which provides wetting to the ocular surface and stabilizes the tear film. It really does what's important with the ocular surface to keep it healthy. What are the functions of a tear film? Well, you want to smooth the corneal surface, of course, moisten, lubricate, and provide nutrients to the cornea, and transfer oxygen from the air from the ambient air to the cornea. It also provides the first refractive surface between the air and the eyeball. So it's important. Of course, it also prevents infection as being the primary surface of the eye, the first surface. So healthy tears, it really consists of a complex mixture of lots of different materials, as you can see on this busy slide. But to highlight some points, there's some suppressors of inflammation, there's soluble mucin 5A-C secreted by goblet cells, and of course there's electrolytes for proper osmolarity. Well, when we get into the dry eye stage, well, the chemistry of the tears change. We have decreased growth factors, decrease in many important proteins. We have altered cytokine balance, which promotes inflammation. And soluble mucin 5A-C is greatly decreased. We have loss of goblet cells, and we have damage to the eye. This damage can be permanent damage on the cornea, on the conjunctiva, on the whole entire surface. So although we may think of dry eyes as being more of a nuisance, it actually can cause irreversible damage to the eye if not treated properly. Many of our patients, especially of cataract age, are on multiple medications. The ones that come to mind are the psychiatric medications. Those are very common, along with beta blockers, preservatives and tears, and topical anesthetics, and histamines, of course. So there are many different causes, but we have to, of course, look for primary medications that patients are taking that may be contributing to dry eyes. So the way I like to grade the severity of dry eyes, I like to use a 4-step classification here. And we look at really mild dry eye. It's very episodic. It's environmental stress dependent. And MGD is normally present, but tear break of time can be variable. Schirmer score can be variable. So the couple things I want to highlight on this slide, Schirmer score is really not used much anymore. It's inherently variable in the early stages of dry eyes, only really helpful in a severe case of dry eyes. So it doesn't get you much info until you're really advanced in the staging of dry eyes. Tear breakup time is one thing that I underutilize personally. Does everyone do tear breakup time in the clinic? Most people? Yeah? Good. So it's an important documentation because in order to get some of these other medications covered, we need to document signs and symptoms. Symptoms we can document with a questionnaire, a speed questionnaire, some of these other questionnaires that we use. But to document a sign, we have to have some sort of keratitis, we have to have a tear breakup time documented, something documented that shows the dysfunction of the tear film. So, 10 is kind of your magic number here. Tear breakup time less than 10, or greater than 10, is more mild to moderate dry eye. Greater than 5, of course, we're getting into more severe dry eyes. And immediate tear breakup time is extreme dry eye. So that's a good number to remember. Of course, corneal staining, conjunctival staining can show no staining to filaments and scarring and symplepharon. So it runs the gamut. Of course, in early dry eyes, the symptoms can be much worse than the signs, or vice versa. I think we've all seen patients that have corneas that look terrible, they're lighting up like Christmas tree lights, and the patient has no complaints. Now, I don't have any problems, my eyes are perfectly fine. So the signs and symptoms do not correlate. So once we get those two together, we can figure out a better game plan for how to treat our patients. All right, so here are the symptoms of dry eyes. We've gone over this. I think most people are familiar, but itchy eyes, foreign body sensation, blurred vision is a big one. Fluctuating vision is a very common complaint with dry eyes. We've all seen patients that describe that, and the first thing I want to do is give them a bottle of artificial tears, do something as a first step to see if it helps. Photophobia, but one thing that we need to kind of focus on with is itchy eyes. Is this a dry eye situation, or perhaps it's an allergic situation? Without any testing or further follow-up, we could try a preemptive course of tears to see if it helps, but we need to think about allergic conjunctivitis, conjunctival chalasis, lid malpositioning, other things that can be mimicking dry eyes, viral conjunctivitis. So we can't just automatically assume that patients have dry eyes. We need to do an exam and point of care testing. So as we mentioned, the clinical presentation can vary significantly. With more severe dry eyes, we see staining of the cornea, we see filaments on the cornea. With more mild dry eyes, we may just see staining on the inferior cornea. So my tip here is fluorescein is a good stain. Of course, we should all be using fluorescein to check, but lissamine green is another really good stain that looks at the conjunctiva to see how that's doing. How many people here use lissamine green? A couple, okay. By the way, how many dry eye centers for excellence do we have? We've got a handful. Okay, so you guys know all about this, right? Lissamine green is a very important stain to look at the conjunctiva, and the ocular surface is not just the cornea, it's also the conjunctiva, so it'll give you valuable information about it. All right, so tear film breakup time, everybody knows how to check that. It's non-invasive, it's easy to assess. It kind of gives you a first step about the lipid layer assessments of the cornea. And of course, staining and corneal sensitivity, tear film osmolarity, these are all things we can check with point of care testing in our offices. The other inflammatory marker, which we'll get into, is the inflammadry, or the MMP9 marker, which can be tested right in the office and can give you a good indication of whether or not you have an inflammatory component to your dry eye, which many of them are. All right, corneal sensitivity, I think everybody knows how to do this. Use a wisp of cotton, check every sector of the cornea, see if there's any hyposthesia in any section of the cornea. Tear film osmolarity, many of us are using tear film osmolarity tests, and once we're getting above 300, it does show a hyperosmolar, 306 kind of your cutoff, hyperosmolar tears, which we can then use to gauge how the patient's doing. I think it's better to show the patient they're making progress rather than actually the initial diagnosis of dry eye, but it's a really high number, obviously, it gives us some useful information. Next was this inflammadry that we mentioned. It's a very easy test. It's basically looks like a pregnancy test. where you check the tears for elevated levels of MMP9. Gives you a simple positive or negative. So if it's positive, you can show the patient, and it's something they can easily understand that there's an inflammatory marker in my tear film. So I know some people are doing that here. If you have the patient read their own test, they are a little more engaged about what's going on, and they want to do whatever it takes to make that, turn that positive to a negative next time around, and there are ways to do that. So this is an easy, how many are using inflammatory in the room? We have a couple? One? Okay. So it's there's no special certificate you need to use it. It's an easy one to do. It's Clear Lab Wave though, right? Yeah. That's my understanding. You don't even need a certificate in Clear.
I've had one for our PS anyway.
Okay. So that's another thing that you can incorporate into your dry eye centers here. So we're going to get into really MGD. So the biggest points that I want to make are dry eye is an inflammatory disease that leads to irreversible damage to the ocular surface, number one. Number two is MGD is present in almost every case of dry eye there is. There's some studies that show 90+%, 95%. In this particular one, 86% of dry eye patients had an MGD component to it. So we have to treat the MGD if we're going to treat dry eyes. And the reason why this is important, we're going to get into later on, is it affects our outcomes as surgeons. Dr. Kovach, where are you back there? So we as surgeons would love to have a nice, pristine ocular surface before we're going into surgery, before we're taking our measurements, so that we can get accurate measurements, we can get consistent and better results, and we can get happier patients. So I know we've gotten that message out numerous times, but the more the better. The more you can do on the front end to treat ocular surface disease, dry eyes, it makes our life much easier and it leads to happier patients. Okay, Dr. Jessica Henke is going to get into this later, but we have up top here mybography, which shows the structure of meibomian glands versus the function of meibomian glands. You can't really tell by just the picture alone how the meibomian glands are doing until you push on them. You have to actually measure the function of the gland. So she's going to get into that more later on tonight, but there's both components when we're looking at meibomian gland disease. Liposcan is one way in which to measure the glands, and the function of the glands is just checked by pushing on the glands in the office, and becoming familiar with that technique, knowing how to grade your function of your glands. Early on, you can see, fairly healthy but smaller or dropout of glands, which can increase as the severity of dry eye, the severity of the meibomian glands drop out over time. I do want to mention TearCare, Sight Science. They have a product which is out front. It is a way to treat MGD, which is done so with the eyes open. There's no need to close the eyes. It's done with an eye open, it's done with a natural blink, and it does heat the inner temperature. They tell me up to 111 degrees. So it's getting to the adequate temperature to treat MGD. The only thing that it's lacking so much is some of the expression of the glands, and that's where it's important after doing this treatment to manually express the glands yourself. That's one of the differences with this product and LipoFlow. This is the newer design with the smart lids. It actually conforms to the lids. It's just external heat, so there's no internal heat. That's how it differs from LipoFlow. There's a patient that's having a treatment on the left, and then on the right, they have a little forceps that they use, that they recommend to express the glands, but any method that you prefer or that you're comfortable with can work. Okay. All right, so we have high-risk patient categories for dry eyes. We obviously talked about pre-surgical. This applies to cataract surgery. This applies to pterygium. This applies to LASIK. It applies to refractive surgery. Perioperative ocular surface disease needs to be treated, and preferably more on the early side rather than waiting until it's right before surgery. Glaucoma patients have a higher prevalence of dry eye disease, along with contact lens wearers, especially with that and MGD is correlated directly. I think Dr. Henke is going to get into that. And patients living a modern lifestyle, well, you know, life has changed. We're all on computers, cell phones, and screens. And younger patients may be on them more than we even recognize or would want to know. So patients staring at screens, obviously they have more MGD. They're not blinking as much. They can have severe dropout of the glands and pretty severe dry eye at a very young age. From a pre-surgical standpoint, there's a study here shows about 63% pre-cataract patients have dry eye signs and symptoms. I think it may be higher than that. You know, I was in surgery last week with an older gentleman who had very severe MGD, and during the case, it literally looked like fruit. You guys remember Fruity Pebbles? Anyone ever have Fruity Pebbles? Right? Those little flakes. And with the lipid layer, they're, you know, rainbow and all these colors, but literally there's these flakes floating around in the tear film for about 10 minutes throughout the case, which interferes with what we can see and we know is a sign of MGD. But this happens. This happens sometimes during LASIK. You know, very often during LASIK we see mucus strands or some other strands at the end of the case that are coming from the meibomian glands that can interfere with flap adherence or get in, you know, get underneath the flap. So that does play a role, right? It does play a role in surgery. So the more we're able to treat it up front, the better off we are. All right, cataract surgery have evaporative stress, especially patients with MGD who are undergoing cataract surgery. Now this may not be such a crucial situation for those with monofocal IOLs, but those that are undergoing a premium, an EDOF, or multifocal IOL, they're at high risk for developing visual discomfort, ocular discomfort, or suboptimal vision due to the unstable tear film. So pre-treatment of MGD can optimize surgical results and can optimize the pre-surgical testing that we need in order to get a good result. All right, glaucoma patients are on many medications. There's a lot of preservatives going into the eye. Glaucoma and MGD are highly correlated. This is a chronic disease where they're going to be using drops or bombarded with preservatives for the rest of their life. So we need to monitor their ocular health, and anything we can do to tune that up is very helpful. Contact lens wear, we know that contact lens and MGD is definitely correlated. We know that blink rates and MGD are correlated, so we're going to get into that a little bit more of that in the next talk. So in the old paradigm was wait, right? Wait for patients to complain, manage symptoms and signs as they present, and be more reactive. So I would do this all the time. Well, okay, you're complaining about itchy, watery, fluctuating vision after surgery. Well, try some tears, right? Take tears and hopefully things get better. But the new paradigm has switched to where we need to diagnose early. This room is full of very, very, very competent primary eye care providers. And part of being a good primary eye care provider is looking for things that the patient may not know they have. And that's where really focusing and honing in on ocular surface diseases is very important. Treat the cause of the dry eye, not just the result. So treat the inflammation, treat the obstruction of the meibomian glands, rather than just replacing the tears. Of course, be proactive. You guys have long relationships with your patients, so you want to treat the short and long-term focus, the ocular surface health of your patient throughout their expected life, and that's a long time. So it does help and behoove us to really focus on this. Of course, tear film supplementation. There's one tear that bears mentioning is fresh coat here, which has a high oncotic pressure, can actually help the epithelial cells by pulling the water out of the cells. There are some other tears that may do this as well. This is one that I want to mention on. For more severe cases, we have different modalities, autologous serum tears. That can be used for more severe dry eyes. It actually works very, very well. I'm sure a lot of you have had experience with that. So it depends on how bad your dry eye is. Obviously, there's more treatments. But Really important treatment is anti-inflammatory therapy. Typically that starts with a topical cyclosporin or lifitegrast. These are the only two FDA-approved agents for dry eyes. They both work by attacking either T cells or further downstream inflammatory mediators which cause the inflammatory process for dry eyes. Restasis or cyclosporin has been shown to increase conjunctival goblet cell numbers. But steroids are also very important. Usually when we start dry eye treatment, we want to begin a steroid in the induction phase for dry eyes. Obviously that means ruling out anything viral, anything more not related to dry eyes, but steroids are very, very important. We need to use that for anywhere from 4 to 6 weeks to load patients up. Yeah, Steve, you have a question?
What steroid would you recommend, or which one do you use?
So I like to start with kind of a mid-potency steroid, typically a Lotamax or a Flarex, one of those that can be used for a month with very low chance of having intraocular pressure rise. It's a good question. Also, oral tetracyclines are helpful with metalloproteinase activity, dietary changes, omega-3s. These are all part of what we can do to change the environment of dry eyes. Cequa is the newest cyclosporin. It is 0.09%, so it's almost double that of Restasis. It does have much better absorption from what we can tell because of this nanomycel technology. It's able to get through the tear film and incorporate or get into the cornea more effectively and the ocular surface. 3 times more absorption in the cornea, 1.6 times in the conj. And an important note that important piece of data, they have 65% of central corneas are clear after 3 months. And that central cornea is where vision comes from, so that's a pretty powerful data that they have. Procera ring is another one that I really like to use in more moderate to severe dry eye cases before surgery. It's anti-inflammatory, it's anti-scarring, it's pro-healing, and it's used to treat a variety of different conditions, including KCS or dry eyes. So when it's needed, don't hesitate to reach for it. I really think that everyone in this room should be comfortable with putting the Procera ring in before we see them for surgery, if needed. All right. So you got to hit home on the carry home message, but the lifestyle questionnaire here is we're really focusing on cell phones, tablets, computer screens. It's an important part of everyone's life, and if we're not really getting ahead of this, we're going to have more and more problems with our patients later in life. All right, so let's get over to prevalence in cataract surgery. 80% of patients had probably a dry eye level 2 or higher based on signs and symptoms. That's a very high percentage. Ocular surface evaluation before cataract surgery is very important, and looking for subtleties like EBMD as a differentiator from dry eyes, also something we need to be familiar with. So in the last few minutes here, we've got about 6 more minutes, I'm going to hone in on a case study here, right? So this is a patient that's having cataract surgery, let's say. This is a 7-year-old patient. This is our topography on the left eye. This is what it looks like. So what do you guys think? Is this a good topography, bad? Is this regular, irregular? What do you think? Anyone want to take a stab at this? What's that? Weird, right? Not good. Not regular. So we have all these hot spots and flat spots. The red is hot, the blue is flat. We have a simulation of how the patient's seeing. And we have some astigmatism here, some higher order aberrations. But it's cornea, just you looking at it, we know it's not good. And let's take this case where we have right and left topographies and placido ring. So let me have somebody take a stab. Which eye is dry here? Right, left, or maybe both? Anyone want to take a guess? Todd?
I can't see if it's the top one says right or left.
Top one is right.
Yeah, right.
Right. So that one's pretty obvious, right? We got this big red hot spot, it's irregular. It's not a nice bow tie astigmatism. Something's going on here. We have a 42.5 average K. Left, we have a 41. Looks pretty regular, but that is a little flatter of a K. So that's something we need to pay attention to. So if we look at average case here, there's a difference here. If we just take this patient and say, yeah, that looks pretty regular, let's run the measurements, we come up with a 22 diopter IOL, put it in, patient may not be so happy, because if we look at the rings, we see that these rings are not sharp, they're a little smudgy, a little blurry. You can see it over here too, these rings.
What do you do differently with an EBMD patient?
EBMD, you get more of a focal area.
What do you do surgically different?
Not really. Same surgery. So actually, treatment with dry eye treatment, your Ks have changed drastically, right? We went from 41.5 to 43.5 in the left eye as well. So the left eye was dry, right eye was dry, much more regular. Ks are actually equal, kind of what we'd expect with both equal eyes, and those placido ring images are much sharper. So this can have a profound effect of surgery. We can have a multiple diopter shift in our IOL based upon these numbers. So if we're getting garbage numbers in, we're going to get garbage results out. That's just the fact of life. We need to have good numbers coming into our formulas in order to get good results. So this does play a really important role in the outcome and happiness of our patients. So I can't stress that enough. Question, yes?
About how long would a dry eye treatment take to postpone the surgery? Because some people are pretty anxious to want to come in and get done right away, and then they go, oh, well, I had to be treated for this and that. It took me so long to get the surgery.
It's a good question. It's a good question. Obviously, it depends on the severity of the disease, what you're seeing on exam, what your topography looks like. But the one, if you don't remember anything from this lecture, just remember this, that there's an old adage. I was at the meeting in San Francisco, the Academy meeting, but everybody keeps saying is that if a complication is not, or potential complication is not discussed ahead of time, and then after surgery the patient's complaining and you say, oh yeah, you have dry eyes, then it's the surgeon, i.e. the optometrist, one of us' fault. It's not the patient's fault, it's one of us' fault because we did surgery. If it's discussed ahead of time, the patient realizes they have a chronic concomitant disease and needs to be treated ahead of time, then it's no longer the eye care provider's fault. The patient understands that they have a chronic disease that needs to be tended to for the rest of their life. Does that make sense? Okay, so, yeah, and one more question back here.
Yeah, what is the end point of this? This is improved from the first slides, but where do you stop and say you've gotten the best result you can get?
I think looking at your images here, you can tell that you're pretty close. Right? If you look at your Myers, your rings here, those are nice sharp Myers. They're not smudgy. They're regular. So you get a gestalt about when you're close enough to, or when you can proceed. But really, it's depending on how the image looks and how things have stabilized. You may have to repeat your topography more often, but in this case, looking at the pictures, you feel comfortable
Are you more concerned about the central case than the peripheral?
Of course, central 4 millimeters is most important, but you want to look at the whole picture. Okay. All right. So oftentimes we hear patients describing issues in their post-op care, and very often it's related to dry eyes. So the more it can be honed in before surgery, the easier it is for the patient, the better it is for the outcomes. I know I said this about 5 times, but that's really the take-home message of tonight. Okay? Any other questions that you guys may have? No? All right, good. Well, we're right on schedule here. So 7:30, we're going to move on to the next section of our talk.